This is Andy Alsbaugh with Duke University School of Medicine. In this presentation, we will explore unique aspects of pneumonia that develop in patients who are hospitalized or who are in other healthcare settings. Consider this patient who is an otherwise healthy 32-year-old admitted to the hospital after a serious car crash. 3 days into the hospitalization, the patient develops fevers, shortness of breath, and a cough productive of purulent sputum. The chest X-ray on the right shows a new right upper lobe infiltrate consistent with pneumonia. What are the features that distinguish the potential causes and treatments of pneumonia in this hospitalized patient compared to a similar patient who develops pneumonia while at home? In this talk, we will define features that distinguish pneumonia that develops in healthcare settings from community-acquired pneumonia. We will also consider the changes in patients' microbial flora when they are hospitalized or otherwise debilitated. And lastly, we will determine how these microbial changes might affect the diagnosis and treatment of subsequent pneumonias. Let's begin with some very important definitions. Hospital-acquired pneumonia, or HAP, is defined as a pneumonia not present at admission that develops after a patient has been admitted to the hospital for more than 48 hours. Among different types of hospital-acquired pneumonia, when pneumonia occurs after intubation and mechanical ventilation in an intensive care unit, it is referred to as ventilator-associated pneumonia, or VAP. Pneumonia developing in patients who are not actually admitted to hospitals, but who have extensive healthcare exposure, is referred to as healthcare-associated pneumonia, or HCAP. This would include residents of nursing home facilities, patients who receive outpatient hemodialysis, or those receiving frequent outpatient IV therapy such as antibiotics or chemotherapy. Why is it so important to distinguish these patients from those who reside in the community? Many studies have demonstrated that the microbial flora of the oropharynx changes dramatically when patients are hospitalized or otherwise debilitated and dependent on others for their daily care. The typically very benign bacterial species of the oral cavity, such as microaerophilic streptococcus species, are often replaced in hospitalized patients by other bacteria, such as enteric gram-negative rods. Additionally, patients with more extensive exposure to healthcare settings are more likely to become colonized with resistant bacterial pathogens, such as methicillin-resistant Staph aureus or MRSA. Now, remember, the bacteria present in the mouth and the pharynx are often those that ultimately end up in the lungs to cause pneumonia. Therefore, these predictable changes in the microbiota of hospitalized patients directly influences the pathogens likely to be present in a hospital-acquired pneumonia syndrome. Let's think about the concept of aspiration in a bit more detail. One can contextualize most episodes of pneumonia as resulting from a microaspiration event. Now, most of us will breathe small amounts of our pharyngeal contents into our lungs during the course of a normal day. Whether it is the normal inhabitants of our upper respiratory tract or these hospital-acquired pathogens, many bacteria end up in our lower airways. Now, most healthy individuals do not routinely aspirate large volumes into their lungs, and the bacteria that do end up there are effectively cleared by normal mechanisms of mucociliary clearance. Now consider what happens in hospitalized patients. Many of these patients are going to be quite sick and debilitated, and they may have reduced ability to productively cough or protect their airways, increasing their risk of large and small aspiration events. Also, as soon as patients are intubated for mechanical ventilation, there is now a direct path for microbial entry into the lungs in and around this plastic tube. Finally, many patients in hospitals are going to be immunosuppressed for various reasons, including cancer treatments or steroid use. All of these factors contribute to the increased complexity of evaluating and treating patients with pneumonia in the hospital. How do patients with pneumonia present while in the hospital? Most will have similar signs and symptoms as outpatients, including fevers, chills, shortness of breath, chest pain, or cough. Also, the presence of purulent sputum, focal lung findings on physical examination, and new infiltrates on chest X-rays are also useful clues for the hospital clinician. Remember, however, that many debilitated patients may not manifest all of these signs, and they may be unable to tell you about new symptoms, making regular assessments of your inpatients an important part of good medical care. In many outpatients with community-acquired pneumonia, clinicians will often choose empiric antibiotics for the treatment of uncomplicated pneumonia syndromes with few diagnostic tests. In contrast, most hospitalized patients with pneumonia should have more extensive clinical evaluations for potential causes. These might include blood cultures to assess for bacteremia, sputum stains in cultures, frequent assessments for adequate oxygenation, and serial exams and x-rays to ensure improvement of the infection. Also, astute clinicians are always aware of special circumstances in their patients that will predispose them to unusual causes of pneumonia. For example, patients with cystic fibrosis are frequently colonized with Staph aureus and resistant gram-negative rods such as Pseudomonas species. Neutropenic patients who develop pneumonia have a larger number of potential pathogens that must be considered in addition to the more common causes of pneumonia. These other pathogens include fungi such as Aspergillus species, as well as viruses such as cytomegalovirus. Now, patients with AIDS or organ transplants are also at risk for developing opportunistic pneumonias, such as that due to Pneumocystis jirovecii. Lastly, debilitated patients can be at high risk for large volume aspiration events, and care must be taken to protect these patients from inhaling oral contents into their lungs. While pursuing these various diagnostic strategies to identify pathogens causing pneumonia in your hospitalized patients, it's often wise to begin therapy while you are trying to identify the specific pathogens. Now remember, hospitalized patients can still develop pneumonia due to the same organisms that cause community-acquired pneumonia, so your therapy must often include macrolides or tetracyclines or quinolones to cover atypical bacterial pathogens, as well as more typical bacteria such as Streptococcus pneumoniae and Haemophilus influenzae. Also, most clinicians will want to include expanded coverage for the enteric gram-negative rods that so frequently colonize the upper airways of hospitalized patients. This often means adding good gram-negative rod agents such as third-generation cephalosporins, anti-pseudomonal penicillins such as piperacillin, or carbapenems. Also, agents effective against MRSA are also frequently indicated if resistant Staph aureus colonization is either known or expected. Finally, it's vitally important that you understand the local resistance patterns of pathogens frequently identified in the patients in your institution. For example, hospitals in certain regions of the country have high rates of colonization and infection due to very resistant bacterial species such as multi-drug resistant Acinetobacter or carbapenemase-producing Klebsiella species and other gram-negative rods. These bacteria often require focused and aggressive antibiotics tailored to their unique antibiotic susceptibility patterns. In conclusion, patients who develop pneumonia while in healthcare settings are truly a unique population. They often have an altered microbial flora that places them at risk for developing infections due to pathogens very uncommonly identified in community settings. Debilitated or intubated patients are at increased risk for both microaspiration events and large aspiration events that result in pneumonias. Also, their comorbid conditions and frequent immunosuppression make them less able to fight off infections once they begin. I will challenge you to be very aggressive in your diagnostic approaches in your hospitalized patients to identify specific etiological agents of pneumonia. When designing treatments, you will always remember that community-acquired as well as nosocomially acquired pathogens will need to be considered. Lastly, it's important to continually familiarize yourself with the common microbial species isolated at your institution, as well as their resistance and susceptibility patterns.